is Dr. Suzan. Perfect. Dr. Suzan works at Postoperative medicine in Haifa, Israel, and the Institute of Pain Medicine at Rambam Healthcare Campus. She's got an interest in COPS and Opioid-induced Hyperalgesia, and she's here to make the rest of us feel old. Thank you very much.
Thank you. So first of all, I'd like to thank Dan Carr and the organizing committee for inviting me. It's a great pleasure to be here. This tall, white building here in the center of the picture is our Faculty of Medicine in the city called Haifa, where I come from. And this is where I recently finished my PhD under the supervision of Professor Elon Eisenberg. And as you can probably see, we have some really nice views from the top floors, so I invite all of you to come and visit. So my talk today will discuss some aspects of acute opioid tolerance and hyperalgesia. Is it significant? And I hope that by the end of my talk, you will all agree with me regarding the significance of this phenomenon. So I'd like to start by presenting a case study of a 16-year-old male who underwent the surgical removal of the third molar. During surgery, our patient received a continuous infusion of remifentanil titrated to a target concentration of 3 nanograms ml and midazolam as required. 10 minutes after the end of the surgery, our patient woke up screaming from pain, which seemed very much abnormal to the treating team. He needed an IV dose of tramadol in order to relieve his pain. And I would like to ask you, what do you think that this patient experienced? Was it acute withdrawal, or perhaps was it acute opioid-induced hyperalgesia, or perhaps was it something else? So when we discuss the acute, I hope that by the end of my talk we'll be able to answer this question. So when we discuss the acute opioid-induced alterations in sensitivity to pain, we have a large spectrum. On the one hand, we have the favorable effects of analgesia. But on the other end of the spectrum, we have hyperalgesia. And hyperalgesia can be caused by several phenomena. So they could be acute withdrawal, acute tolerance, acute opioid withdrawal, or acute opioid-induced hyperalgesia. So clinically, these three phenomena may seem very much alike because the end result is increase in pain intensity. However, both in terms of treatment and in terms of mechanism, these are three distinct phenomena. So what I'd like to do next is to define each of these phenomena. So when we discuss opioid tolerance, we discuss the physiological adaptation to the presence of an opioid so that increased doses are required in order to maintain the same level of analgesia. The pain due to opioid tolerance, the increased pain due to tolerance, is usually limited to the regional site. Now, the time frame in relation to opioid administration is during the administration of opioids. How can we treat tolerance? We can either increase opioid dosage, we can decrease the between dose interval, or in case of incomplete tolerance, we can use opioid rotation. What about opioid withdrawal? So this can be produced by abrupt cessation, rapid dose reduction, or the use of an opioid antagonist. The pain can be either localized or diffused pain, and the time relation to opioid administration is following the cessation of opioid administration. The treatment could be a gradual reduction in opioid dosage. The last phenomenon I'd like to describe or define is opioid-induced hyperalgesia, or briefly OIH. So this is a paradoxical response whereby the administration of opiates for the treatment of pain actually causes higher pain sensitivity. Clinically, this increased pain can be either at the original pain site, or we can sometimes see the appearance of new and diffused pain. Now, the time frame in relation to opioid administration is during the administration of opioids, which is different from what we see with opioid withdrawal. Now, the treatment is reduction in opioid dose, which is not the same as we see with opioid tolerance. So regarding opioid-induced hyperalgesia, this phenomena has been studied for over 30 years, and there are nearly 500 publications in humans on this topic. So this phenomena has been studied in 5 major groups. The first one is healthy volunteers following the acute opioid exposure, by using different experimental pain models. The second group is acute postoperative pain in patients undergoing surgeries. The third group is patients who suffer from chronic non-malignant pain. Cancer pain patients, usually at the end of life, these patients receive megadoses of opioids, and opioid addicts. So since our topic today is acute pain, I'll concentrate mainly on the first two groups. So how can we study opioid-induced hyperalgesia in healthy volunteers? We need to apply some experimental pain tests. This could be a measurement of secondary area of hyperalgesia or allodynia, or applying some experimental pain stimuli such as thermal or electrical stimuli. And these tests should be applied twice, prior to and following the administration of short-acting opioids, which is usually remifentanil or placebo. So let's take a look at some examples. So I'd like to draw your attention to several important aspects in these studies. So first of all, as you can see, all of these studies used remifentanil as the ultra-short-acting opioid. Now, remifentanil was administered for a time period of 30 to 100 minutes. And opioid-induced hyperalgesia was tested by different experimental pain models, secondary area of hyperalgesia, electrical pain stimulation or heat pain stimulation. Now, the interesting thing is that opioid-induced hyperalgesia was measured in these and lots of other studies, actually, after the cessation of opioid administration, after the cessation of remifentanil administration. So I would like to ask you, what did these studies really measure? Was it true opioid-induced hyperalgesia, or perhaps was it acute opioid withdrawal? Since the measurements were after the administration of opioids and not during, I think that these studies probably measured acute withdrawal rather than true opioid-induced hyperalgesia. So this is the case with healthy volunteers, and I would like to move on to the second group, which is perhaps the most studied group in the context of opioid-induced hyperalgesia. So when we discuss postoperative pain in opioids, I think we can divide opioid administration to 3 time frames. And these are opioid administration during surgery, preemptive opioid administration, and chronic preoperative exposure. So let's take a look at the first time frame, which is opioid administration during surgery and postoperative opioid-induced hyperalgesia. So these studies basically utilized a very similar paradigm. They compared the effects of ultra-short-acting opioids to those of a comparator. Now, a comparator could be either a placebo or a lower dose of opioids. Data on opioid-induced hyperalgesia was collected post-operatively, data on postoperative pain and analgesic requirements. So let's take a look at some of these studies. The first study describes 60 patients who underwent a C-section surgery who received either fentanyl or saline in addition to the local anesthesia. So this study found increased post-operative opioid requirements in the fentanyl group as compared to the saline group, and this was seen during the first 24 hours post-surgery. Another study with similar results on hysterectomy patients who received high versus low doses of fentanyl. This study found increased early postoperative pain and opioid consumption in those patients who received high doses. A third study on major abdominal surgery also found increased postoperative pain and morphine requirements in patients who received intraoperative remifentanil infusion. And the last one published earlier this year found that patients who underwent elective thyroidectomy and received remifentanil versus non-remifentanil anesthesia, those patients who received remifentanil anesthesia actually suffered from increased postoperative pain in this group that received remifentanil. So again, I would like to ask you, what do you think that these studies actually measured? Was it a true opioid-induced hyperalgesia, or perhaps, again, was it acute opioid withdrawal? So the same as with healthy volunteers, data on opioid-induced hyperalgesia was collected post-operatively, thus suggesting that it was actually acute opioid withdrawal and not opioid-induced hyperalgesia. Now, the fact is that at least in some of these cases, increased doses of opioid were required in order to manage this postoperative pain. So if this was a true case of opioid-induced hyperalgesia, we would have seen a pain relief with lower rather than higher doses of opioids. So I would like to move on to the second time frame, which is preemptive analgesia. So these studies compared active analgesics, such as NSAIDs, local anesthesia, NMD antagonist, opioids, and gabapentinoids, to a placebo, which was administered shortly prior surgery. Again, data was collected regarding post-operative pain, supplementary analgesics, and time to first analgesic. So a review published by Ong and colleagues about 11 years ago actually compared these different preemptive analgesia to the common post-operative treatment regimes. You can see here that they used quite large number of studies with numerous of patients, and they actually found that as compared to other medications, opioids actually produced the worst results. And this was true for post-operative pain, for supplementary analgesics, and time to first analgesics separately, and when they combined with these three outcomes together. These meta-analyses, as well as some other meta-analyses, led to the publication of the guidelines on the management of post-operative pain. Now, 2 of the 32 recommendations refer to preemptive analgesia, and these are recommendation number 16 and 17, which recommend considering the administration of preoperative celecoxib, pregabalin, and gabapentin as a good preemptive analgesic choice, but not opioids. The last time frame I'd like to discuss is the chronic opioid exposure prior surgery. So again, these studies compared the chronic use of opioids prior surgery as compared to a non-opioid analgesics. Data was collected regarding post-operative pain, hospitalization duration, and opioid prevalence consumption. So these are just some examples. You can see here that most of these patients underwent orthopedic surgeries with a time duration of opioid consumption of at least 4 weeks. And you can see here that the results regarding the opioid group were very much unfavorable, with increased post-operative pain during hospitalization, with a slow rate of post-operative pain resolution, and with higher opioid doses during hospitalization. So to sum up the first part, I think that we've seen there are 3 lines of evidence that show that opioids alter sensitivity to pain in the acute context. And these are opioid administration during surgery, preemptive analgesia, and chronic exposure prior surgery. A second point is that intraoperative opioid administration, as we saw, can lead to clinical hyperalgesia. But it seems to actually represent acute withdrawal rather than the true phenomena of opioid-induced hyperalgesia. But regardless of the terminology and the exact definitions, I think that you will all agree with me that opioid administration both pre and during surgery has negative impact on acute post-operative pain. So far I've showed you how not to measure opioid-induced hyperalgesia, and for the time I have left, I would like to show you how we can measure opioid-induced hyperalgesia. A statement before that, one of the major problems with post-operative pain is that it's a major contributor to becoming chronic pain. So this is one of the major problems with this issue. So now regarding opioid-induced hyperalgesia, I've showed you how not to measure opioid-induced hyperalgesia. So how can we measure opioid-induced hyperalgesia? True clinical opioid-induced hyperalgesia is quite rare, and it is seen mainly in cancer pain patients who receive megadoses of opioids, usually towards the end of life. These patients sometimes develop increased pain intensity, which can be reduced by the reduction of opioid dose. And this phenomena in the clinics is quite rare. But another way to measure opioid-induced hyperalgesia is by utilizing experimental pain tests. So a review published by Katz about a year ago showed that heat pain stimulation has some promising results in this regard. So I'd like to show you a study we've conducted in our lab about 3 years ago in patients suffering from chronic pain. So we had two main aims in this study, and they were to establish a model examining the development of opioid-induced hyperalgesia during 1 month of hydromorphone treatment in patients with chronic neuropathic pain. And the second aim was to explore whether experimental hyperalgesia can correlate with the change in clinical pain intensity following treatment. Study population consisted of 30 patients with chronic radicular leg pain, and study medication was hydromorphone, which was individually titrated to 4 to 24 milligrams a day. Pain assessments included both clinical and experimental pain assessments. Clinical pain assessment included pain and disability questionnaires, and experimental pain was assessed by the application of a tonic phasic heat pain stimuli in a remote and a healthy area. It was applied to the tenor of the hand. Now, the study design consisted of two sessions. Patients were assessed twice, at baseline and following 1 month of hydromorphone treatment, while they were still receiving opioids. So let's take a look at the results. First of all, you can see here that the change in clinical pain intensity following 4 weeks of treatment was quite robust. We saw a decrease in 25 visual analog scale points. So this finding is not surprising. We have given those patients analgesics, and this is quite consistent with what we see in other randomized control trials. When we look at the distribution of change in clinical pain intensity, and here each dot represents the change for each patient, from baseline to 1 month of treatment. You can see here that 25 patients experienced clinical pain reduction, while 4 patients experienced clinical pain elevation. So this is regarding clinical pain. Now moving on to experimental pain. What happened to those patients, to the experimental heat pain intensity of those patients following 1 month of treatment? We actually saw an increase in experimental heat pain intensity following 1 month of hydromorphone treatment. Again, let's look at the distribution, this time of experimental heat pain intensity. We saw a reduced heat pain intensity in 12 patients, increased heat pain intensity in 17 patients, which we can now refer to as opioid-induced heat hyperalgesia, and 1 patient reported of no change. So the next thing we wanted to test was correlations between these 3 parameters: hydromorphone dose, opioid-induced heat hyperalgesia, and opioid-induced analgesia. So our first finding was a positive correlation between hydromorphone dose and opioid-induced heat hyperalgesia. We actually saw that this phenomena is dose-dependent. Those patients who consumed higher doses of opioids were the same patients that developed higher extent of opioid-induced heat hyperalgesia. Now, the second finding was a negative correlation between the hydromorphone dose and the clinical analgesia. So the patients that consumed, again, higher doses of opioids were the same patients that benefited less from this drug. And the last and perhaps the most interesting finding was the negative correlation between opioid-induced heat hyperalgesia and clinical analgesia. Those patients that developed a higher extent of opioid-induced heat hyperalgesia in a non-painful area were the same patients that benefited less in terms of clinical analgesia. So I'd like to finish by suggesting some clinical criteria for the diagnosis of opioid-induced hyperalgesia. So when can we suspect OIH? First, when we see increased pain intensity during an ongoing opioid treatment, when there is no evidence for underlying disease progression, when there is no evidence for clinical or pharmacological opioid withdrawal, when there is no evidence for opioid tolerance, when we see decrease in pain intensity in response to opioid dose reduction, and when there is no evidence for addictive behavior. Thank you very much.
Very nice and clear report. I actually learned that we, in the acute pain setting, have opioid-induced withdrawal and not opioid-induced hyperalgesia, which is basically a wording problem, but if you are looking for the phenomena and the mechanism, this might be very important. Thank you very much. Questions?
Yeah, I'd like to argue a little on your withdrawal considerations, because, in experimental studies, these are patients without ongoing pain. They just have pain when you do your pain stimuli. So what we did with the experimental pain was remifentanil for 30 minutes, no pain afterwards, and then after 1 hour we did our pain test. And the opioid hyperalgesia patient had more pain, and that could not be withdrawn in my definition. And also I would argue that if you speak about withdrawal, many of these cases with remifentanil have proven more pain afterwards compared with desflurane and sevoflurane, which is evenly rapidly withdrawn from the body. So I would ask a little about this withdrawal definition of yours.
Well, I think one of the major differences between opioid-induced hyperalgesia and tolerance and Preemptive withdrawal is the time we test for pain intensity. This is not opioid-induced hyperalgesia. I think if we test for pain intensity, whether experimental or clinical, after the cessation of opioid administration.
But I mean, if you have ongoing pain, if you stop suddenly a painkiller, could be inhalational anesthesia, could be opioids, you will have pain, and that's withdrawal, I think. And hyperalgesia is when your pain threshold is lowered in a situation where you should expect it to be higher.
Yes, but I think again the important thing to remember here is the time, is the time frame in which we administer opioids. You're correct, but again, I think the differentiation should be regarding the time frame of opioid administration.
But I think the point is valid by asking for what the mechanism are behind different in patients with pain or in patients without pain, and contributing to the analgesia or analgesic effect of opiates. I think this is a valid question, and we don't know really. We know a little bit from, as I know, I'm not an opioid-induced hyperalgesia expert, but we have animal data, not we, for example, Suzan or others have animal data by showing that the mechanism, as far as I know, are very similar, at least in reducing opioid-induced hyperalgesia and the withdrawal of opioids. And this is actually not just remifentanil, it is the other opioids are inducing the withdrawal at least as well. Can you comment on that? You're the expert.
Yes, this is true. I think that mechanisms are perhaps a bit different, but there is some overlap. Yeah, we can see it with opioid receptor internalization, yes. Which are, I think, a common mechanism for tolerance and opioid-induced hyperalgesia, for instance, and some other mechanisms as well.
Okay, thanks. That's another question.
Yeah, thank you. I think it's a very interesting effort to define a very complex problem and find diagnostic basically by elimination. But my question is more related to the use of pregabalin and gabapentin, because there is evidence, according to your presentation, that you are not the only one to say that it is a recommendation for preemptive analgesia. We conducted probably the only trial with Pfizer on hundreds of patients, placebo controlled, and we did not find anything. And my question is, where is the argument for this guideline to come? Because as far as I am concerned, when we compare placebo and the administration of pregabalin on hysterectomy, hernia repair, and other models, we did not find anything. But clearly it is out there, and clearly the company was able to achieve something they could not achieve by a well-controlled trial.
Sorry, I just want to jump in. This is Deb Gordon. I worked on the American Pain Study Guideline. I think there's two different discussions. I think what Dr. McIntyre was talking about perhaps was a little more about post-operative use of pregabalin. The APS-ASA guideline recommends a single preoperative dose. It was not very definitive on post-operatively. The data I've seen on systematic reviews of post-operative pregabalin and gabapentin, really shows maybe in, I think what they call the program-susceptive models like amputation, spine, orthopedics, but not in the visceral models and other things. So again, talk about timing and dosing. The APS, Dr. Charles Evans guideline did not find any risk of respiratory depression with preoperative gabapentin.